Okay, this section of our lecture says some common pictures of steroids and some of the variety of forms in which they are available. And our objectives for this particular lecture are that you should be able to, tell me what the two main classes are of steroids, explain glucocorticoids, explain mineralocorticoids, and describe at least 3 adverse effects associated with chronic steroid usage. So first, before we start talking about steroids, we kind of need to talk a little bit about the adrenal glands. Now, if you recall, the adrenal glands are located on the upper surface of each kidney. The one on the right kidney is a little bit more triangular shaped. The one on the left kidney is a little bit more oblong shaped. And the adrenal gland itself, if you look at the picture, the cross-section, when you cross-section it, has 2 parts. It has a medulla, which is the center, and then it has a cortex, which is the portion around the outside of the adrenal gland. Now, the medulla, we're not going to spend a whole lot of time talking about. The cortex is the one that we're a little bit more interested in. And the cortex is composed really of 3 layers. So that outer layer really has an inner, a middle, and an outer layer also. And each of those layers releases hormones. The hormones that are released from the cortex of the adrenal gland are referred to as corticosteroids. This is where we get the term steroid from, and this is why we, as lay people, just tend to say steroids, because it's real long to say corticosteroids, in that they are steroids that are originating from the cortex of the adrenal gland. But the technical term really is corticosteroids. And these, there are really 2 main types of corticosteroids: the glucocorticoids and the mineralocorticoids. And we're going to take a look at each of those types individually. So we're going to start with the glucocorticoids. Now, the glucocorticoids regulate the metabolism of carbohydrates, proteins, and fats. And they do this especially during stress. So when you get periods of stress, and not just talking like, oh, I'm stressed out about a test. Yes, it kicks in then. But I'm also talking about stress that involves injury to the body, trauma, or surgery. They are stress on your body. When that happens, your body needs more glucose. It needs glucose to heal, it needs glucose to send cells, it needs glucose to respond to the stressors going on. So the adrenal glands start to kick in high gear to help assist with the body meet its glucose needs. Now, the main physiologic effects of the glucocorticoids are accomplished by 2 main metabolic processes. They are able to promote gluconeogenesis and protein catabolism. Again, the 2 main processes of the glucocorticoids are gluconeogenesis and protein catabolism. Gluconeogenesis is the process of making glucose in the liver. So it takes products from the liver and turns it into new glucose from glycerol and amino acids, and then puts it into the bloodstream. So that's the process of gluconeogenesis. converting amino acids or glycerol into glucose, then putting them into the bloodstream. Catabolism, on the other hand, is the breakdown of proteins and into amino acids. If you remember from way back in the day, proteins are made up of chains of individual amino acids. So what catabolism does is it takes those proteins and breaks them back into those individual amino acids. And where this occurs is mostly in the skeletal muscle. So the amino acids that are released can then be used by the liver to make more glucose. So if you understand that, catabolism kicks in during time of stress, takes proteins from the skeletal muscle, breaks them down into individual amino acids, sends them into the bloodstream where they're caught up by the liver. The liver now takes them and converts them into glucose through the process of gluconeogenesis. So those are the two main roles of the glucocorticoids in the body. Now there is a kind of a third thing that plays in a little bit with this that is going to come in as we start talking about the medications a little bit more. These glucocorticoids also have the ability to cause us to retain sodium. So it makes the kidneys hold on to sodium. And as we start talking about some of the things that go on when we give people glucocorticoids, you'll understand some of the side effects by understanding that that is kind of a side effect of them. And what happens is when you hold on to kidneys, if you recall, hold on to sodium from the kidneys, you're also going to hold on to water. Salt attracts water. And then you get fluid retention in the body. So now, what effects do glucocorticoids have on the body? If we give someone glucocorticoids, probably the most important use of them is if we have someone who has the fancy word adrenocortical insufficiency. Okay? In other words, the cortex of their adrenal glands is not working enough. So we would need to provide them with glucocorticoids as a replacement therapy for what their adrenal glands aren't putting out. Commonly, this is known as Addison's disease. The other thing that we highly use glucocorticoids for is in treatment of inflammation. So we're looking at the two primary uses as being replacement for adrenocortical insufficiency and as an anti-inflammatory agent. So when someone has Addison's disease, they have a deficiency of both, believe it or not, glucocorticoids and mineralocorticoids. And their symptoms are usually that they've got dehydration, they have low blood pressure, and muscle weakness. So that's how that person usually presents. So when the plasma levels of the glucocorticoids and mineralocorticoids do not rise or can't be detected, that's how we know that someone has Addison's disease. So they're either non-existent or we stress them and they won't rise in the blood levels. Someone who has Addison's disease must receive continuous hormonal replacement therapy for the rest of their life. So they have to replace those missing steroids from their body for the rest of their life. I want to spend a little bit more time, though, talking on the anti-inflammatory action of glucocorticoids. And this is probably the one you're most familiar with. The glucocorticoids are what I would consider the most potent anti-inflammatories around. What happens in the sometimes normal inflammation ends up being a little too intense for the body. Inflammation, if you remember from human illness and disease, is good for your body. It's your body's response to injury to helping it heal itself. But sometimes our body goes a little too far when it's responding, and the inflammation ends up causing other issues, or it ends up lasting much longer than it should. And then now the inflammation, instead of being productive, becomes more of a problem, and then we have to treat it. There's also sometimes we have conditions where we actually need to suppress the inflammatory process for other reasons, such as systemic lupus erythematosus or any other autoimmune diseases. So there's also other times where we may want to go and keep the inflammatory process from kicking in to begin with. So glucocorticoids are very useful in those situations. They affect actually pretty much every single cell in the human immune system. They have an effect on mast cells and eosinophils and neutrophils and macrophages and lymphocytes. Every cell in the immune system is affected by glucocorticoids. And as a result, they really have three ways in which they will decrease inflammation in the body. The first way is the corticosteroids reduce the secretion of vasoactive substances. And by vasoactive, I mean substances that cause the blood vessels to dilate. If you remember, that's part of the inflammatory response. The blood vessels dilate and allow leakage of cells and fluid into the surrounding structures, and which then subsequently causes edema or swelling. Corticosteroids have the ability to stop the body from releasing the vasoactive mediators that dilate the capillaries. So the capillaries do not dilate, and as a result, the fluid doesn't leak out, and therefore the edema decreases. The second way in which they work in the inflammatory response is that the corticosteroids actually restrict the accumulation of white blood cells and macrophages. So by keeping white blood cells from accumulating, they again halt the inflammatory process. Less white blood cells, less inflammation. And third, they also inhibit the release of destructive enzymes, specifically lysosomes. And if you remember, those lysosomes attack injury and debris and destroy the surrounding tissues. And that means it'll destroy normal tissue as well as non-normal tissue. So if we go and inhibit the lysosomes, keep them from activating, then subsequently we slow down the destruction of tissue. And specifically, we want to slow down the destruction of the good surrounding tissue. So glucocorticoids play a role in decreasing the activity of those lysosomes. So it's a three-pronged approach that attacks a number of different physiologic processes within the inflammatory process that really makes these glucocorticoids an excellent choice when we're dealing with conditions of inflammation. So, now that you know how they do that, what would be the primary reasons that we would use a glucocorticoid? In other words, what are the common clinical indications for glucocorticoids? Glucocorticoids such as prednisone are really used for a wide range of inflammatory disorders. And these would include things like arthritis or ulcerative colitis, like we talked about in our GI system, multiple sclerosis, allergic reactions. For example, the poison ivy allergic reactions. Respiratory disease, which we spoke a little while ago. We did the respiratory system. And as well as non-allergic inflammations that occur. So anytime you get inflammation that's occurring that is becoming a problem, that's becoming a symptom and causing other issues such as pain, we are looking at the possibility of administering a glucocorticoid. We can give them in several different ways, as you would have seen on that first video or that first slide that we had, and that is we can give them orally, we can give them intranasally, we can give them intramuscularly, intravenously, or topically. So we really have a wide range of ways that we can get glucocorticoids into the body, depending on how quickly we have to get them in and depending on where actually the inflammation is. For example, we may use the glucocorticoid topically for an inflammation of the skin that is localized in a small area instead of putting it systemically into the body. Okay, so now that we know how they work, what we use them for, what are some problems we have with administration of glucocorticoids? The biggest things that we see, or I should say the most common things that we see, not much biggest, most common or most frequent, would be an increase in appetite and weight gain. We may see some indigestion and restlessness. Long term, you might see what's called hirsutism, which is hair growth in places where you may not want hair to grow, particularly if you are a female, and you may develop a mustache or a beard and may not want those things. Some less frequently, you may see some things such as a change in skin color, might see some dizziness, sweating, flushing of the face, and skin rash. And as you start getting into those last couple, the dizziness, sweating, flushing, and skin rash, those are getting more serious, and they're ones that we definitely may want to look at changing the medication with. Now, in patients who are receiving high doses or have long-term treatment with glucocorticoids, the adverse reactions are really exaggerated, really exaggerated effects of what we see in the normal reactions. And in fact, we can see things that look similar to Cushing's syndrome, which is the excess corticosteroid production. The other issue that we do have to keep in mind with this is, if you recall, it's decreasing the inflammatory response. So as a result, people are not able to respond to invasions that come into the body. So as a result, it immunocompromises people. So that also needs to be kept in mind in long-term usage of glucocorticoids. In that case, sometimes we use what they call an alternating day therapy, whereby 1 day on, 1 day off, 1 day on, 1 day off. And that seems to help with some of the long-term steroidal effects that we see in someone who's on these medications for a long period of time. Okay, so the mineralocorticoids are hormones secreted by the outer layer of the adrenal gland, as we identified earlier. The main effect of the mineralocorticoid hormones is to regulate the fluid balance of the body. What happens, take you a little bit back to anatomy and physiology, is if you remember those nephrons that are in the kidneys, are responsible for the formation of urine. And there's a substance called aldosterone which increases the reabsorption of the sodium ions. It is produced by the adrenal glands. When you absorb sodium, you also absorb water. Okay? So, aldosterone, which is a mineralocorticoid, is responsible for the body being able to hold on to water. When you have a deficiency of this hormone, it's called hypoaldosteronism. Okay? Aldosterone being the hormone, hypo being below, ism is the condition. So in hyperaldosteronism, we have this condition where the body cannot hold on to sodium or water. Usually this is caused by someone either having the adrenal glands removed, an adrenalectomy, or they have a tumor on the adrenal glands. So what we do is we have to replace the mineralocorticoids so that the body is back into a homeostatic balance. If you think about this, the side effects of mineralocorticoids would then be to maybe retain too much sodium and water. So you may get a high level of sodium in the body. So you would see things like hypertension and edema. You might see some arrhythmias. And then in addition, the body, when it's holding on to sodium, it exchanges it for potassium. So if it's holding on to sodium, it means it's dumping potassium out. So you could also see low potassium levels, in which case then you may see like some muscle weakness and that going on because the people's potassium level gets low. So those are the most common side effects that we see, adverse effects that we'd see of mineralocorticoids. And again, it's usually due to too much mineralocorticoid in the body, and is very quickly able to be regulated by just decreasing the dosage. This chart should look familiar to you in that it comes right out of your textbook. And these are just some things to think about when we're talking about people who are on long-term steroid therapy, whether it be the glucocorticoids or the mineralocorticoids. Since steroids universally affect the metabolism, patients who are on these long-time must be observed carefully for changes in body weight, electrolyte balance, and cardiac function. Sodium retention associated with these drugs may also lead to elevated blood pressure, hypertension, and edema. So patients should really be weighed and be weighing themselves almost daily to monitor for these changes in their body weight. They should also be used cautiously in patients who have gastrointestinal ulcers, renal disease, CHF, ocular herpes simplex, diabetes mellitus, emotional instability, or they have psychoses. In all these conditions, the steroids can really exacerbate the underlying disease and can make things worse. They really should not be used at all in patients who have systemic fungal or local viral infections, such as herpes infections. As we talked about, what can happen is they can go and end up decreasing that inflammatory response to the point where the body cannot go and get rid of the fungal or the viral infection, and it'll just make it worse. So those are a couple things you do want to keep in mind In addition, I would not recommend giving a vaccination which has a live virus in it to someone who is on steroid therapy. Again, because of their decreased immune response, they could actually end up with the virus now that you're vaccinating them against. So I would also take a caution if a patient is on a is on steroid therapy. Don't get your flu vaccine. Wait till they're completely off the steroid medication, and then get the flu, and then get their vaccine. And talking about that, taking them off. If someone is on a long-term steroid therapy, they really should be gradually, slowly weaned off the medication. You don't want to discontinue these medications quickly. You want to gradually pull them back so that the body can gradually adjust to the effects of no longer having them in the body. Gradually pulling them off can make a patient pretty miserable, and you actually go almost through like a steroid withdrawal. So just as a side note there, wean patients off slowly when they're coming off of steroid therapy. And just a kind of a little funny to end our lecture here. You may recall people talk about roid rage and the effects of steroids. And again, long-term overusage, as we talked about, can cause these effects. So you do want to take these medications seriously and don't take them lightly.